But the other option, the more common, or I guess I would say more reliable and lower risk option, is to do what we call a bone anchored hearing implant. And I can do that myself at the same time as I do the ear reconstruction. So we're right next to each other. It's a very easy kind of add-on to my ear reconstruction to put an implant in. And today, boy, there's a lot of options for what type of implant you can use from multiple different companies. And honestly, every 2 years, it seems to get better and better.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
This week on First Case, we speak with Dr. Sheryl Lewin, pediatric plastic surgeon based in Torrance, California, who focuses on ear reconstruction and also happens to live right near you, Paul. And I really want you to tell your story of how you met Dr. Lewin, because I think it's really serendipitous.
It really is serendipitous. My dentist is in the same medical office building as Sheryl. While her office was being built, I had gone in for an appointment, and he said, hey, he knows I have Microtia. And he said, hey, there's a new doctor coming in who's going to be performing a surgery on little kids right next door. At the time, she wasn't in the office yet, so I couldn't go over there and introduce myself. But I looked her up on LinkedIn and sent her a message and told her, my story about having grown up with Microtia and that I was an OR nurse and that I wanted to meet her. And you'll see when we talk to Dr. Lewin that she is just an amazing person. And she got back to me right away and said, yeah, I'd love to meet you and talk to you. Why don't you come into my office on a Wednesday? Because that's when we unveil the kids after their surgery so they can see their ear reconstruction. So I did that and was just blown away by the results. And we became friends after that. She asked me to become part of her foundation, and I've been contributing to her foundation every year since I've met her. Because of COVID, she didn't have one of her annual seminars, but I'm hoping that this coming year I'll be able to attend that and meet some more of the folks, more Microtians like myself, as we like to call ourselves. She's just a great person.
I can only imagine how special that Wednesday was.
It was incredible. Of course, it makes me wish I was young again so I could have had the surgery myself. But in my late 60s, it's probably not the best option for me to go ahead and do it. I suppose I could, but everybody accepts me for the way I am. I don't think there's a need. So.
Well, I'll tell you what, this is going to be quite an inspirational and enjoyable, relaxing conversation today with Dr. Sheryl Lewin. So stay with us. We're going to be back after a short break.
Hi, I'm Paul Wafer.
I'm Melanie Perry.
I'm Jeremy Gibson-Rohr.
And I'm Justin Poulin.
A 17 Studios production, you're listening to First Case.
Joining us now is Dr. Sheryl Lewin, pediatric plastic surgeon based in Torrance, California, and focusing her practice on ear reconstruction. And I know that you know Paul pretty well because he's the one that made the introduction and got you set up for the interview. But really excited to have you on and talk about your specialty, but also just what a great job you're doing. And we'll make sure to promote your website by the end of this, because I think anybody who goes there and sees the work is going to be duly impressed with what you're doing. So welcome to the show.
Thank you so much. Really, really appreciate you inviting me and excited to tell you a little bit about what I do.
Well, why don't we start right there? Why don't you talk about your background? Even before we got on air, you have done a lot related to plastic surgery and specifically with pediatric population. But then at the same time, you've really become a specialist because this is all you have time to do now. So walk us through how you went through your career and got to this point.
Okay, sure. Well, it probably starts a little bit before medical school because I actually was an architect by training in college and then really pivoted my career towards medicine after college. And what was interesting in med school then was I missed all the creativity and artistry of architecture, and that really led me down one path, which was plastic surgery. And more specifically, I was absolutely drawn to pediatric plastic surgery. Just loved these kids, and they had these facial deformities or conditions. And to me, the surgical treatment is very much art.
Sheryl, I don't think the people listening to this podcast know, but you know that I was also born without an ear, and I didn't even know what the condition was called until much later in life. I probably was after nursing school even, and it's called Microtia and Atresia. And I'm wondering if you could tell us what's the incident rate of this and what are the causes and prevalence across the country and around the world?
Sure. So Microtia literally translates to mean little ear. So it's a baby that's born with just a tiny bit of extra skin, but no actual ear and no ear canal. That's the Atresia term, means no ear canal. It is really rare. 1 in about 8 or 10,000 babies around the world is born with this condition. It is seen worldwide, but maybe more prevalent in certain areas and certain ethnicities. And sadly, we just do not know the cause of Microtia atresia, why a baby would be born like this, because only 5% is seen as a genetic passed down from parent to child or through a family's genetics. 95% of the time, it's unusual combination, maybe partly environmental, but very rarely do we actually know what causes Microtia. It happens what we call sporadically. So just, any couple could end up having a child born with this, and we don't really know why.
So what created your interest in reconstructing ears? What was your impetus towards heading in that direction?
So once I knew that I wanted to do pediatric plastic surgery, you take a specialty training called a fellowship in craniofacial surgery. And that's where I really got introduced to where I trained at Children's Hospital Los Angeles, a very large population of these patients that really is not seen in those numbers probably anywhere else in the country. It just, in some way, I was in that, for me, very lucky right place, right time to see all these kids. And there was not a great solution at the time. There was not a perfect solution. There were attempts that really needed refinement. So to me, I was so attracted to two things. One, the surgical problem, of course, is known in plastic surgery to be one of the biggest challenges in all of reconstructive surgery. Really, total ear reconstruction is right up there against anything else. But two, I will say, having spent, 15 years working with Microtia families, I do find there's just something incredibly special about these kids and these families. And it's hard for me to put it into words, but I just see it and witness it every single day. And what a wonderful way to spend my life, helping out these amazing kids.
Yeah, I mean, I can only imagine. You said it was, one of the more difficult procedures to do. And during your experience, you were really noticing the fact that you didn't think it was done well enough and that there were these attempts that needed refinement, your words there. But what makes it so difficult, right? Just for the audience, why is this not easier to do? And why is there, even in, the 2020s, we have a real standout, procedure and method that you've developed that isn't necessarily standardized yet?
Correct. So what it is, so plastic surgeons, we live in this world of almost sculpting the body. Okay. So whether it's cosmetic surgery, breast reconstruction, hand surgery, there's so many different areas, and we are sculpting the body. But if you think about your own body, you look at the form and function of an ear, and the only thing that really rivals it is the form and function of your nose. So of all the things, you've got a complex shape supported by, cartilage, skin, ligament, all these different things. And to get that shape is it's much more difficult, not to take anything away from a breast reconstruction surgeon, but the breast itself is a simpler form, and we're a little more able to recreate it. Whereas the ear is just one of those things that has kind of defied many people's attempts to come up with a, quote, standardized solution. And so for me, this was an amazing opportunity, that I didn't realize I would, but have now devoted my entire career towards the challenge of trying to develop a better solution.
How much of it is, you compared it to the nose, how much of it is it the lack of bone structure to be able to shape that?
Structure in both of those cases is super important. And for your nose, you have to have a type of a structure when you're creating a total nose that allows airflow through and the proper type of, we call it mucosa, what lines your nose and your mouth on the inside, structure to support it, and then tissue that looks as normal as possible on the outside. So that's this 3-layer thing. Well, what we're doing is similarly 3 layers for the ear. You need a structural support that, in my case, I use an implant that I created, but in other surgeons' hands, they use rib cartilage. And then you need coverage over that structural support and skin to make it stable. And so that whole process for me is, an entire day, 8 or 10 hours in the operating room to basically build this sort of living sculpture that will be durable throughout one's life. That's the hard part. It has to, believe it or not, your ears actually take a lot of, daily wear and tear, and you have to create something that's going to work for people and their daily lives, albeit not totally normal as their other ear, but at least to appear, the goal being to appear normal enough, so-called normal, though we hate that word, but typical enough that nobody actually notices your ears.
As an OR nurse, my brain jumps to what you do in the OR. I've done a lot of plastic surgery, especially skin cancers and Mohs reconstructions, and we've dealt with, ears on adults, and I worked ENT where I, worked with kids and we did tubes and that kind of thing. But thinking about reconstructing the ear makes me think not only the external ear with plastics, but the internal ear with ENT. Do you work together with ENT when there's a hearing loss issue so that you'll team up for that patient, or is it separate surgeries?
It is, I guess, to answer your question, a little bit of both. Okay. So it depends on the solution. So for hearing, almost all these kids have significant hearing loss. Some opt or prefer not to augment their hearing because they can get by if they have one normal sided ear. They may do perfectly fine and not want a hearing solution. But then there's 2 major categories for the hearing. One being recreation of a canal, which is done by a very specialized type of an ENT doctor. And that would be done first in a separate surgery. And I would come later to do the ear. But the other option, the more common, or I guess I would say more reliable and lower risk option, is to do what we call a bone anchored hearing implant. And I can do that myself at the same time as I do the ear reconstruction. So we're right next to each other. It's a very easy kind of add-on to my ear reconstruction to put an implant in. And today, boy, there's a lot of options for what type of implant you can use from multiple different companies. And honestly, every 2 years, it seems to get better and better.
Sheryl, I think you know that I tried one of those bone conduction hearing aids, but at my age and it didn't work well for me. It was almost too disruptive. But I would think that with younger kids, if they have it early on in the process, it's a much better outcome for them, right?
Yes. And you bring up a really good point. I remember a patient, quite a long time ago in my practice, and she was in her 70s, and she was referred to me by her ENT, but she had had a canal procedure done, like in her late 60s. And she was so frustrated because it turned her whole world upside down to have that kind of a change, and she couldn't control it. Like, you can't turn off your ear canal. So in her case, you could see how starting that late had a detrimental effect to her outcome. However, as you're exactly right, Paul, many audiologists will offer what we call a soft band bone anchored hearing aid. So it's the processor just on a little headband, goes around a baby's head, and they can get it, as young as 6 months for a unilateral baby, or a unilateral meaning one-sided typical ear and one microtia ear, or a child that's bilateral where they're missing both ears would get that immediately at a month of age, so they can start developing language.
So what's the best time to start the reconstruction on a child? What's your recommendation to parents for that?
Well, I'll tell you, we consider Microtia atresia like an orphan disease. And as such, almost nobody knows what the condition is when the baby is born. Okay. The parents end up literally going to the internet to research little ear, baby born, whatever they can to themselves define even what they have. So honestly, due to the lack of education and resources out there, I like talking to parents of newborns or infants. The other interesting thing, how our world has changed in healthcare over this last 2 decades, or last decade for sure, is the orphan diseases now have homes around the world where everybody that has that condition can all meet up into one central place. And it's a chat room, whether it's on Facebook or some other platform. And it's become not only a way to educate, but to get resources to these patients. And so I'm quite sure most of my patients come to me from these chat rooms where former patients are talking about their paths. So from a parent's perspective, I like to educate right away. And then we first discuss hearing options, because that's what we can affect in those first couple years. And they're not going to get their ear reconstruction till they're older, 4 years old perhaps, or later. So we just talk on a yearly basis to kind of update them on what's new before the actual reconstructive process starts.
You mentioned earlier that it takes like 8 to 10 hours in the OR when you do take a patient to surgery, but can you walk through the actual procedure, what it is you're doing, and then maybe the steps that you're taking while you're in the OR?
Absolutely. So it starts a little bit before the OR, because for my technique, we're going to 2 months before use a 3D scanner to capture the image of the child's typical ear. And then because they may only be 4, 5, 6 years old, we're going to grow up the ear to adult size using design software. And then once I get my final design, we have time for the company that produces it, a company called Peripherus. They make a porous polyethylene 3-dimensional patient-specific ear implant, and that's called Supor. And I'll get that implant back, and then on the day of surgery, we go to the little ear, and we basically use every part of the little ear. So the skin is elevated, then the earlobe is elevated, then the cartilage is removed and reused for reconstructing a portion of the ear. The implant is then carved on a back table. And then the hardest part of the day is what we call the flap. We create a flap, which just means a piece of tissue that has its own blood supply and nerves. And that flap lives above where your ear sits, underneath your hair and skin and fat of your subcutaneous tissue, the flap sits right under there, and it's called fascia. And so taking that fascial flap out without any incisions in the scalp is a bit of a dissection. So have to spend a little bit of time on that. And once we have that tissue, it's like a big kind of fan-shaped tissue. It sounds so simple, but we just lay it over this implant and attach a suction, and we shrink wrap that living tissue onto our 3-dimensional ear implant. And it literally just does that. And it's like, that's the moment. We call it the suck down, and everybody gets really excited and they all look. We put on the suction, and then like an ear is born right then and there. So then the last thing is covering it with skin. And that actually takes me a long time because it's a lot of sewing and really fine technique to get the best scar pattern, the best color to the ear. Skin grafts come from the abdomen and the other ear. So we put the whole thing together. And then the last thing is probably 30 minutes to protect it with a special custom cast so that, you know, the kids, they're ready to go 1 week later to see their ear.
Okay. So I have 2 more questions. This is fascinating to me, but what about the staff in your room, your circulator and your scrub tech and the other people you have in your room? Do they have to be specially trained for this, or do you have people that you specifically want to work with to do these cases?
So that's a great question. So just like you can imagine with any specialized team in healthcare, and they've even done research on this, when you have people that are just a dedicated team to a certain type of operation, you have less complications, less OR time, a smoother surgery. And there's no doubt in my mind that my unbelievable, amazing team, they shave easily an hour or more off of my OR time than having to do it without a specialized team. It's one of those beautiful things like a symphony, you know, where I put out my hand. My tech knows what instrument I want. I don't have to ask for it. My nurse knows when to exercise the arms. It's like, it's this beautiful like dance that everybody knows how to do. And it's just wonderful. It's my happy place.
I was team leader for orthopedics at my last job, and being in my realm with what I know how to do, I'm good at it, and I'm comfortable at it, and I can make the process go faster in the room if I know what I'm doing. So it makes perfect.
I will add, so I guess in 2017, I decided to create my own operating room, and it's completely and solely dedicated to Microtia reconstruction. And when we did that, you know, these team members that are there day in, day out with these kids, they know their stories. They see them if they come back. There's a lot of like very great TLC that goes on, down to like the craftsmanship of the nurses making decorations on the ear cups that are customized to what the little kid wants. You know, I mean, it's healthcare at its finest in my mind in terms of my team.
I would reinforce that. I did have an opportunity to meet Sheryl's team and go in and observe for a small case. It wasn't a big reconstruction, but the team was fabulous and they treated those kids so well. And then I had the opportunity to go into the office on the day when Sheryl was taking off the ear cup for the first time and see these kids when they saw their ear for the first time. And it was a really heartwarming experience, let me tell you. It was terrific.
Yeah, every Wednesday we get that, and it's really, really great. It's great. I will say I have the best job in the world. I truly believe it. It's just very, very, very gratifying.
Well, what about complications? What about the potential for complications with these patients? What do you normally see if there is one?
So they're complex procedures, so they have like a multitude of possible complications. I mean, there's a list of them. I mean, the obvious ones with any surgery: bleeding, infection, scarring. But with these implants, they're very picky, and there's no real margin for error on the flap that we dissect. If that has an issue, the kid will have a complication. So it's an ability to kind of manage that both in the OR and recognizing anything we can do to minimize complications. And then after, there are some treatments that I can do, kind of wound care treatments for preventing complications. But what you do get, the biggest one would be an exposure, which just means there's a hole where the flap wasn't healthy enough to survive. And then you're looking at the implant. There's, basically seeing the implant. It's not an emergency or anything, but it certainly requires surgery to fix if it does occur. So that's really the big one. The other one we think of is infection, but we've been able to manage infections just with oral antibiotics. So that has not been a significant problem at all.
Sheryl, I know that you are taking care of patients from all around the world. So how do you manage those complications when the patient's down in Guatemala or over in Czechoslovakia or wherever? How does that handled?
So fortunately for me, there is rarely an urgent complication that I can't manage long distance. So if they do get an infection, we can get antibiotics to them wherever they're at. We can get a culture taken wherever they're at. That would be a rare one. But the bigger deal would be if they, get a wound or they get an exposure or a traumatic injury. And, to be honest, every single patient I have ever operated on has my personal cell phone number. And my number's never changing. And I hear from patients from 12 years ago, it doesn't matter. So I'm kind of available to my patients sort of, 24/7, 365. But we do so much education before they go back to their countries that we have a great system. I follow them super closely for 3 months after surgery. Every patient, they're sending in photos and then they send in yearly photos. And we just have this massive follow-up kind of campaign because I'm a low volume surgeon. So I have a lot of attention to detail for each and every kid, but I don't treat that many kids because, if it takes a whole day, I do 80 to 100 a year. That's not a lot of patients to keep up with, over time it is. Over time
I was going to say, after 20 years, it certainly is.
It is.
I can see why it's so gratifying. It's because you can take your time. I remember when I got into nursing, one of the things that I found to be frustrating after leaving an area where I was working with young kids at a summer camp, and there was just so much fun and there was so much energy around that. And then all of a sudden, when I finally graduated, it was like I was grinding on the floors, right? And just doing med surg. And it sucked everything out of what I really enjoyed from becoming a nurse kind of out really, really early on. I actually went and did psych nursing with adolescents to try to get that back. But I can see where you're able to really focus on the patients, make a huge impact, and it's visible, and there's an actual shared moment when you're all doing that together. And then with the complications being so reduced, the risk is low, so the reward is so high and so much more emphasized. Is that a good characterization of your experience?
Absolutely. I could never have envisioned this is where I would be today. I'm sort of the opposite of what I thought I would be. I thought I'd be in an academic institution with a whole bunch of colleagues and lots of different kinds of cases. But I hate to say it it's not surprising. I'm a surgeon, but the level of control I have over my patient's experience from the first second they call me till a decade later, I could never go back to having less control over the patient's experience. It's certainly rewarding for the patients and the families. It's so rewarding for me. And it's sort of funny, but my kids grew up meeting these patients. They are a part of my family, my life. We have yearly conferences. The patients come from all over to these conferences. They meet each other. They become friends of each other and keep in touch. It's like this wild community of all these people related to this. I was born with a little ear, but in my world, it's a very magical thing. I will say, when a parent calls me, when you have a baby, they're born with this condition. You're super stressed out. Your doctor didn't know what it was. You've never heard of it. You don't know a single person who has it. And there's all these questions. You're a new parent. Those patients, I say that right now, all you can think about is the negative, right? Like the problems and all of the bad things. And I say, but I'm the voice of like experience well into the future. I have hundreds and hundreds and hundreds of patients, just like your baby. And they're the most wonderful, incredible little human beings. And I say there's something very special that you won't recognize in your child until later, perhaps. But it could be something that they tend to go in. Look at Paul. They tend to go into fields where they're helping other people. They tend to be very empathetic children. They tend to understand like those deeper things beyond superficial appearance. You know what I mean? There's just something about these kids that I see the positive in, or the other side of being born with Microtia, Atresia, you know, that when you have this new baby, you don't see as well. But I know my older parents, they all know what I'm talking about. They all get it, you know? So it's in a way kind of a neat thing there too.
You described it as creating a community, but it really sounds like you've created an extended family, not just for yourself, but for everybody that is connected through you and this, you know, this procedure that you've refined over all of these years. And you set a glimpse into the future, but so much about what you're doing is innovative. It is sort of a glimpse into the future. And I think part of the reason why you enjoy this is you're clearly an entrepreneur. You're not just an artist, although there is some artistry to being an entrepreneur for sure. But that's something that I think everybody who has something that's their own, that they're dedicated to, that they make it their life's work, you know, has that experience that you're having. And I can't tell you how happy I am for you to hear your story. And I know nobody who's listening to the podcast could see Paul, but I mean, he is, Paul, I don't even know that I've ever seen you this happy, just non-verbally. And and really energized by the conversation, but you're an inspiration. When we talk about the future, maybe you can just kind of talk about how this 3D technology has given more and more refinement, again, to use your word, to this process and where it can go. You know, what is the next step for all of this?
So I think where I sit today, like I always see room for improvement, and I really obsess over how can we do better? How can it drives me and I love it. And even last week, I ordered a new piece of equipment that I'm trying out. Not going to tell you too much about it yet because I haven't proven that it's going to work yet, but I'm already starting this new idea that is a slightly different way to do this dissection that may have fewer complications and better results. So I think that I will inch up bit by bit over the next several years and continue to slowly get better at achieving what our goal is, which is, you know, the opposite ear, mimicking it as closely as possible. I don't know in the remaining rest of my career, 15, 20 years from now, I don't know that something dramatically new and different is going to replace what I do. Unfortunately, there's the trials for these things are so long, 7 years, 10 years. And then if there's problems going back. So I know that will still be worked on. And if something comes up, I will love to incorporate it with my own practice. But for me, I just want to keep pushing my little envelope bit by bit to keep edging closer to my goal, which is an ear that nobody knows was made by me.
Well, I think you've come very close to that, Sheryl, from all that I've seen. I'm wondering if we could spend a minute or two talking about your foundation, Iracles, because, you know, that's one of the things that got you and I involved together. Maybe you could tell the audience a little bit about that program and what it does and who qualifies for something like that?
Sure, absolutely. So I'll tell you how Iracles was born, and the name I credit to one of my dads, who when I came out from surgery to show him the pictures of his child's ear on the, so-called operating room table, he goes, "Dr. Lewin, you perform Iracles." And I'm like, I'm going to steal that from you. So I did. And in 2012, we made this foundation that came out of the need for a patient. My very first patient, her name was Ivy, is Ivy. Her mom desperately emailed me and said, "I have emailed every surgeon in the world that I can think of to help my daughter. She has had 17 operations on her ear and her ear canal, and she looked not recognizable as an ear. I mean, not even close to recognizable, but it was affecting her psychological health. I mean, she was depressed about this, as you would expect anybody would be." And I said, we have got to have a solution for children that are in her state. They've failed sort of standard medical treatment and they have nowhere to go and nobody that can help them. And the great thing about this technique is if some surgeon hasn't, destroyed that tissue, I can take that ear and we can kind of erase the 17 surgeries and start over. So it was born to help those that are most in need, having failed standard treatment, rib cartilage, ear reconstruction, or even the technique I used, but done in a way that was not a success. And so we have people apply that are in that condition and we evaluate them. They certainly have to have enough resources to get to us and come back for a potential complication. But beyond that, we are able to offer free surgery, free anesthesia, and free facility for those children so they can get an ear. So we can do about 6 to 10 kids a year and get them new ears and or partially fund people that, can sort of make it but couldn't quite get to us.
It's a wonderful program, and I'm hoping to help with that any way I can.
Yeah, Paul has been absolutely wonderful helping with Iracles. It's this balance that has always been hard for me to keep the practice under control and still have an ability to help with the foundation. But we actually did a number of cases this year. Despite COVID, we had to restrict, we restricted to American patients this year. We have international patients waiting to come as soon as borders open up, though.
Well, I just want to encourage everybody who's listening to see your work for themselves, because I think they will be equally as impressed as they are by this interview. And they can go to lewinear.com. That's LEWINEAR.com. And Sheryl, you did just a phenomenal job. Quite inspirational, and I'd be surprised if you didn't get some requests for some understudies as a result of this interview.
Awesome. Thank you so much. This is wonderful what you guys do, bringing, things that are not as well known or understood about medicine out to everyone. So thank you so much for your time.
That was Dr. Sheryl Lewin, pediatric plastic surgeon based in Torrance, California. She's focusing on ear construction, as you probably gathered from our conversation today. And, Paul, you told us a little bit of a story about how you met Dr. Lewin at the very beginning before, we got into the conversation with her today. But it was very inspiring. And, I think for you, it probably hit home, more than anybody. And, you've lived kind of a life of multiple surgeries. And I think it's interesting that you met Dr. Lewin sort of haphazardly and not as a result of her work per se. So she did an awesome job. I'm really glad you found her and brought her on the show.
So having been born with Microtia and starting to have surgery at the age of 5, I had challenges with the results of my surgery off and on. And at that time, from 1959 to 1976, there really was no good technique. So in many ways, I was a guinea pig for some of these plastic surgeons. And it wasn't the only thing they did, like Dr. Lewin. I had surgery with a local plastic surgeon in Santa Monica for several years. Then I went to UCLA for several years, and I got no good result. I had over 40 operations over the course of my lifetime on my ear, and it doesn't look like one. So thankfully, when I was in college, I was able to grow my hair long, so nobody knew I had it. And so that's how I had long hair when I met my wife. So, it didn't really bother her, and she's grown to accept it. So it's no big deal. We've been married 40 years. So it's interesting now, though, my grandkids will come up to me and they'll look at my ear and they'll want to touch it and ask me questions about it. I just tell them, I was born that way because I'm special. So, but Dr. Lewin is a wonderful surgeon. And if anybody asks my opinion about who to go to, I'm always referring to her for sure.
All right, well, that's going to do it for this week's show. As a reminder, you can help support First Case by subscribing on Apple, Amazon, or Google Podcasts, as well as Stitcher, iHeartRadio, Spotify, or your favorite podcast application. You can also access bonus content for certain episodes by downloading our smartphone app for iPhone and Android. We'd certainly appreciate a rating and a review because your feedback is important to the show. And I do want to remind everybody that you can see Dr. Sheryl Lewin's work by going to lewinear.com. That's LEWINEAR.com. And on behalf of Melanie and Paul and myself, thank you for listening to this week's episode of First Case.